Hello, good afternoon. My name is Carlos Andrade.
Hello, good afternoon. My name is Lorenclis Alvarado.
Hello, good afternoon. My name is Yritza Castañeda, and our clinical case is minimal invasive mitral replaced with conventional instrumentation case report.
35 fetal female patient with history of controlling arterial fibrillation for 8 years and diagnostic for ER controlled arterial fibrillation and pre-surgical diagnostic of preoperative diagnostic of doubly severe balanced mitral lesion. Mild aortic insufficiency, mild tricuspid insufficiency, and moderate pulmonary hypertension. The surgery was performed as an elective, consistent for mitral valvular placement with mechanical prosthesis and 26. The approach was on right anterior mini thoracotomy, extracorporeal circulation time, ACC, was extracorporeal circulation time was 1 hour 51 minutes, 18 displaying time 1 or 40 minutes. His post-operative stay was satisfactory with an endotracheal intubation time for 18 hours, minimal post-operative blinding total in hospital stay 5 days and no complication.
Surgical technique. A 7 cm long right anterior mini thoracotomy was performed at the level of the fourth intercostal space, avoiding the intercostal nerve vascular bundle. The thoracic cavity was entered, pulmonary collapse was performed with subsequent pericardiotomy. B-cuff venous cannulation. After cannulation, extracorporeal circulation machine, entry and aortic clamping. Anterograde cardioplegy was administered with cardiac arrest in diastole. Left atriotomy and exposure of the native mitral valve. Excision of the anterior leaflet and placement of valve stitches. Placement of the mechanical valve in the usual manner. Closure of the atrium, aortic clamping, and extracorporeal circulation machine. Output: the cannulation. Reviet of the hemostasis. Placement of draining tube and chest closure. For anesthetic management, double lumen tube placement, bupivacaine, infiltration at the time of chest closure, and exhaustive pain management, where prioritized pain management.
Result: patient with a favorable post-operation evolution, fast done surgery with conventional incision. The stay in ICU and in general, the hospitalization was shorter. Result of the surgery with controlled echocardiogram with a normal finding and normal function, mechanical base good asterisk result. Discussion: Minimal invasive pelvic surgery (MEAs) led to significant reduction in postoperative morbidity compared to surgeries performed via median sternotomy (MEAs). mainly increase of intubation time, postoperativity, pain and blood transfusion, as well as significant reduction in mortality, especially in patients over 75 years old. Miss has revolutionized my facet of surgical practice, particularly in recent decades, and includes a significant number of producer MEAs in many alternate creative state conventional surgery with the added adversion of minimal surgical trauma and improving the aesthetic result, speeding recovery and shortening the hospital stay and therefore the hospital stay and therefore costs.